Good morning, everyone. This is Phil Horn with the Missouri Opioid State Targeted Response Project. I am here with Dr. Jay Shiken, who's going to do an awesome webinar this morning on treating pregnant and postpartum women with opioid addiction. So Dr. Shiken is from the St. Louis University Women's and Infant Substance Health WISH Clinic, and she is going to talk about a lot of different topics on the epidemiology and trends in OUD and pregnancy, as well as several other topics. So I will turn it over to Dr. Shiken to begin.
Good morning, everybody, and thank you for allowing me to present to you today. I am the medical director of WISH, which stands for Women and Infant Substance Health, and we are a full-time prenatal clinic that also provides medications for opioid use disorder on site and office-based treatment and counseling, as well as case management and a lot of coordination of care. So with that background, I have no financial conflict of interest to report, and we're learning how to do this. So as the number of prescription opioids increased, and this is cataloged from essentially 1999 in the first decade of this century, what we started to see was an essentially similar pattern in the increase in opioid deaths due to overdoses, as well as admissions for opioid abuse treatment. So it is important for us to remember that 80% of the world's opioids are consumed by Americans, and 80% of heroin users began their opioid use disorder with using prescribed opioids. In 2015, of the 20.8 million Americans aged 12 and older who had a substance use disorder, which based on the National Survey of Drug Use and Health, this is about 8% of the population that were surveyed. So 2 million had a substance use disorder involving prescription pain medications, and 591,000 of these had a substance use disorder involving heroin. And the reason that I bring this to our attention is it's really important to understand that of people who are dying, of people with opioid use disorders, we're not exclusively talking about those who are using street heroin opioids, but may be getting prescription medications that they're either misusing, diverting, or buying off the street. And then if we look at these overdose deaths, and this is carrying this out much further, we see this really precipitous rise in the number of opioid deaths, which really started in about 2011 and then had a more steep upswing starting in 2013 or so. And if we look at what the source is for these opioids, it's that the biggest increase is not in methadone. It's in other synthetic and semi-synthetic opioids like fentanyl and tramadol. So why are people dying? So if you look at the potency of the various opioids, compared to morphine and heroin, heroin is about twice the potency of morphine. Fentanyl is 80 to 100 times as potent, and carfentanil 10,000 times as potent. So the lethal doses, and this is just a visual for you to understand, a lethal dose of fentanyl is 2 milligrams, and this is what a lethal dose looks like of heroin and of fentanyl. And just to put this in perspective, we look at the number of drug overdose deaths compared to other things that have caused high mortality in the past decade or so, that we've now exceeded the number of deaths due to motor vehicle accidents, due to gun violence, and we have surpassed the peak in HIV-related deaths that occurred in the 1990s. So in Missouri, bringing it a little closer to home, there were 951 opioid-related deaths in 2017, which turns out to be 1 out of every 65 deaths in Missouri were due to an opioid overdose. So pregnancy has certainly not been spared this being part of this epidemic. And in this ascertainment is by hospital discharges for delivery, and this is expressed per 1,000 deliveries, hospitalizations. So as you can see, it's pretty much the same trend. We see a pretty linear increase in the number of patients at delivery who carry a DSM-5 for opioid use disorder and whose hospitalizations were marked by having an opioid use disorder discharge diagnosis. So along with this, there's also an increased incidence of neonatal abstinence syndrome. So neonatal abstinence syndrome, I'm going to speak about in more detail in the slides coming up, but it essentially is withdrawal that occurs in newborns when their opioids are withdrawn, and it can occur either as a result of women taking prescription opioids, illicit opioids, or prescription medications that are opioid replacements during pregnancy. So as you can see, there has also been a big increase in the number of admissions to ICUs. Now, this was in a study of 199 ICUs in the United States that admitted babies, and these were just babies that met that had by the ICD-9 codes were logged as having neonatal abstinence syndrome during their hospitalization. But essentially, it went from 7 to 27 per 1,000 deliveries over the course of time from 2004 to 2013. And the length of hospitalization also increased during this period of time, with a median of 13 days to about 19 days. And the percentage of days that were accounted for by infants who were being watched or treated for neonatal abstinence syndrome also increased over this period of time. In Missouri, now the dashed line here represents the time at which we changed from ICD-9 to ICD-10. So there may be some ascertainment bias in this precipitous increase in the numbers between 2015 and 2016. But still, we can clearly see that there is a trend in Missouri between 2011 and 2016 of the number of infants who either had an ICD-9 or an ICD-10 code for NAS during their hospitalization. And what does this cost us? So again, same caveat between 2015 and 2016 based on the ICD-9 or the ICD-10 that was used. It appears that there is an overall decrease in the length of stay for these babies, but because of sheer numbers, the number of costs have increased dramatically. So these are data from the Missouri Hospital Association, and they looked at essentially all insurers and hospital data, again, using ICD-9 and ICD-10 diagnoses, and contrasted and compared the numbers of non-NAS infants with NAS infants. There was an increase in the length of stay, 2 days compared to 12 days for infants with NAS, with a change in charges of about just under $5,000 per that hospitalization for NAS to almost $33,000. And who is paying for this? Well, in Missouri, 50% of births are covered by our Medicaid services, but of the NAS babies, 83% are. So it is our Medicaid that is covering about 83% of these costs. So there are some issues with respect to maternal medical problems associated with opioid use. There's nothing about pregnancy that protects them necessarily from the evils that IV injection drug use or crime associated with illicit drug use may engender. So there's an increased rate of STDs, of HIV, particularly associated with needle behavior, as well as other infections that are also transmitted in this fashion. Endocarditis, pneumonias are more frequently, cellulitis and abscesses from skin popping. Sepsis is more common, and we're starting to see a resurgence in tuberculosis as well. Virtually every body system can be associated with an increase in infection, particularly of the urinary tract. And we're also seeing hepatitis on the rise, and specifically hepatitis C. And you can also have other infections, including osteomyelitis. And remember, these are issues that may require IV antibiotic treatment in the hospital, and getting treatment to IV drug users is really going to be confined to our acute hospital settings, as it's very difficult to find them care outside of the acute hospital setting. So sometimes these can be quite prolonged hospitalizations. We also see abuse of other substances, and even substances that we don't traditionally think of as substances of abuse, things like gabapentin and Benadryl and hydroxyzine. Excuse me for those slides jumping. And we also, this is turning into more mortality, and we, like other states, have seen an increase in maternal mortality, much of which is in the postpartum period, and which we directly relate to postpartum depression and postpartum poisonings, which are overdoses and suicides. Other medical problems associated are anemias and thrombophlebitis and edema, particularly for those with chronic injection drug use. Now, Rh disease probably deserves just a little bit of attention, because women injecting drugs, if they are injecting small amounts of Rh positive cells into their circulation and they are Rh negative, you may start to see some evidence of increased in Rh-related antibodies, and we are seeing this more often than we would care to. Drug use is associated with nutritional deficiencies, and then all of the drug-related behaviors, particularly if women had a drug use issue that was legal and they were dependent, but then someone stops prescribing to them and they all of a sudden have a drug opioid dependence that turns into an opioid use disorder because they're no longer able to legally obtain their medications. And then we're left with theft and prostitution, violence, and which is not limited to partner violence, and they put themselves at significant legal risk. We also recognize the association of mental health disorders, some of which are pre-existing conditions to and contribute directly to their substance use disorder. And sometimes these are conditions that are as a result of their drug using, and specifically depression with risk for suicide and other kinds of psychiatric diseases, anxiety, depression, bipolar, and schizophrenia. Let's not forget that these can be pregnancies that have morbid outcomes. And in this slide, which I apologize is somewhat busy, all the bolded numbers indicate the statistically significant numbers. Now, in this study by Mato that appeared in Anesthesiology in 2014, came from hospital discharge data for delivery, and came from ICD-9 codes that indicated that opioid abuse or dependence was primary in their treatment. But what you see is a 4 points after being controlled for age group, race, primary payer, previous cesarean delivery, multiples, and a host of pre-existing maternal conditions. You see a fourfold increase, and this is a pretty big data set with 60,000 in the ones with opioid use disorder out of these over 20 million charts that were available from this review. You see a 4.6-fold increase in the risk of death during the hospitalization, including a 3-fold increase in the risk of cardiac arrest, growth restriction, placental abruptions, and with a prolonged length of stay, 2.2-fold increase there, preterm deliveries, low amniotic fluid volume or oligohydramnios, increased risk of transfusions and stillbirth, and prematurity, with about a 20% increase in cesarean deliveries. Now, it appears there is some protection against severe preeclampsia. We're trying not to let that information get out too broadly. So we have some alternative treatments for narcotic addiction during pregnancy, and there are the 3 medications that are essentially the opioid replacement medications. Naltrexone is not used to any extent during pregnancy, in that its safety has not been demonstrated. And then I just want to mention detox, and we'll have a couple of slides coming out to talk about that, which is really of limited utility when it's used all by itself. And my tongue-in-cheek way of addressing this is by giving you the chemical formula of heroin. So methadone is a full opioid agonist. Buprenorphine is a partial agonist. And we'll be talking about them for the duration of this presentation. So for many years, we thought that maternal withdrawal would then result in a fetal and intrauterine withdrawal, which was fetal hyperactivity, intrauterine convulsions, passage of meconium, strong respiratory movements, some aspiration in utero, and fetal death. And it turns out this is really not the model that we are looking at anymore. So these data are really not data. Came from a case report in 1963 and from a small series in 1974 in which serial amniocentesis were done in somebody withdrawing from methadone that demonstrated increased levels of epinephrine and norepinephrine inside the amniotic fluid. So we are not as worried now about acute fetal withdrawal effects. These are more contemporary data, and there are other studies that also demonstrate the same findings. Is that if you compare, now there are no randomized control studies that we can really address this more directly. But we do understand that in series, and some of these go back over a period of years, these are the number of patients that were involved, and this is over the years of the study, that we are really not seeing much in the way of acute adverse outcomes related to opioid withdrawal. And these are supervised withdrawal. So particularly in this study, in which women were admitted, stabilized on methadone, and then slowly withdrawn over time, there are some recurring themes. We are not seeing an increase in adverse outcomes, at least in the short term. But what we are seeing pretty universally is not a terrific success rate. So between 30%, and these are described differently in different studies, whether they were actively using. In this particular study, 59% were successful. They didn't complete detoxification, but were not positive for drugs. But we really are not seeing high success rates. I mentioned in the previous slide that these can be morbid pregnancies, and so it is best to have women in sobriety at the time that they deliver to provide the best outcome for infants. So this is that last study that I mentioned, and this really sort of caused a furor in the obstetric community. This occurred during the period of time in Tennessee when there was a fetal assault bill that was in effect. And the fetal assault bill provided that women identified as using opioids during pregnancy could either be going into mandatory chemical dependency treatment or incarceration just for their drug use based on the child abuse statutes. Now, this law was in effect from 2013 to 2015, I believe, but during this period of time, there was still a paucity of chemical dependency treatment slots. And so during this period of time, 108 women were incarcerated and were studied as to their outcomes. Group 2 was a group of women, as you can see, all of these are broken out as to what trimester of pregnancy they were in when they were either incarcerated or entered treatment. Group 2 was a group of people who underwent inpatient detoxification, and these were not specified, but the majority were 3 to 4 day detoxes, followed by an IOP, an intensive outpatient treatment of various durations. Group 3 were people who had inpatient detox and did not have access to IOP afterwards. And then the group 4 are people who were started on buprenorphine in the office and underwent a slow taper during pregnancy. And in speaking to the director and one of the authors of this study, according to him, these were all voluntary. So there were 300 people in this study, and some of these women were still incarcerated at the time of their delivery. Some were discharged earlier. But they had a fairly low rate of neonatal abstinence syndrome and a fairly low rate of relapse compared to those people who had inpatient detox that were not followed by IOP with a 74% relapse rate. And so overall, the issues with these slides, as I'm trying to outline, there have been over 650 women thus far in the literature who have undergone detoxification during pregnancy without any increase in adverse effects. Now, just because you can doesn't necessarily mean that you should, sort of like wearing a bikini. The opioid detoxification during pregnancy, Mishka Terplan did a comprehensive systematic review and found 15 studies that were included for his study, and came up with similar evidence. The quality of the evidence is pretty poor, and there was a risk of bias, and there really were no randomized controlled trials during this period of time. There is not the evidence right now to really support detoxification as a first-line intervention, with, the nice intended effect that you could decrease the risk of neonatal abstinence syndrome, but that it's associated with high rates of relapse, and we don't have any data regarding long-term follow-up. So as I go back to that study in 1974, which indicated that were higher levels of norepinephrine and epinephrine in amniotic fluid of women who are undergoing withdrawal, these repeated sorts of stress, almost like a toxic stress, we don't really understand what the long-term implications of this must be. So I'm just going to mention that even though we don't think there's any acute effects associated with neonatal withdrawal, neonatal abstinence syndrome still occurs. So this is characterized by neurologic excitability, and these are the factors that we see. Sorry, I keep jumping ahead here. And this is how an infant is going to manifest, with tremors and irritability and difficulty sleeping and a high-pitched cry. Almost always have increased tone, not necessarily rigidity, but are characterized by hyperflexion and some hyperactive reflexes. And this really does not look very much dissimilar to what withdrawal would look like in an adult. But because there are mu receptors in the GI tract, there's also specific issues with GI dysfunction in terms of feeding and the CNS effects of uncoordinated sucking, but also direct effects on the GI tract in the way of vomiting, diarrhea, which increases the risk of dehydration and poor weight gain. We also see the autonomic signs of increased sweating and nasal stuffing, much like you would see in an adult with the temperature instability. So we're going to talk about now the full agonist methadone versus the partial agonist buprenorphine. So as these medications attach to the mu receptor, the antagonists like naloxone and naltrexone do attach to the mu receptor but don't activate it. The partial agonist, buprenorphine, will attach to the receptor but not fully activate it. It's actually sort of a weak agonist as far as that goes, compared to the full agonist, methadone. And the point is to understand is there is a ceiling effect that's noted with buprenorphine compared to methadone. And this has some implications potentially for the newborn. But aside from the things that I mentioned with the caveats about detoxification during pregnancy, there are clear benefits of using opioid replacement. And I do have to give you a warning in the slide, since we're not calling it MAT anymore. We're calling it either meds or pharmacotherapy or medication for opioid use disorder. Some of my slides still say MAT. We're all talking about the same thing. So it's associated with a decreased illegal opioid use, and it also is associated with decreased use of other drugs. We slows the spread of HIV and other sexually transmitted diseases, and also decreases the spread of hepatitis C through decreased injection drug use. There's decrease in crime. It also prevents the fluctuation of maternal drug levels during the day. So there is a decrease in craving and a decrease in drive to seek drugs. There's less mortality, and it may decrease the risk of neonatal hypoxemia in infants that are otherwise fragile and are going to be at risk, because it provides a more stable intrauterine environment. There increase in birth weights compared to women who continue to use heroin. There's a decrease in neonatal mortality, so deaths within the first 30 days, and it promotes retention in prenatal care. So therefore, narcotic replacement with either methadone or buprenorphine is considered the standard of care during pregnancy. So just some quick things to outline the difference with methadone and buprenorphine with a specific eye on pregnancy. So methadone, you know, has to be given by an OTP and is generally dosed daily, where buprenorphine, given by an office-based practitioner, can be done once daily, twice daily, sometimes 3 times daily. Methadone is given orally, buprenorphine by the sublingual route. One thing that is key is that in order to start methadone, it requires being in the hospital or an OTP. Now, while you don't have to be in active withdrawal to get methadone from an OTP, in order to meet criteria for medication stabilization in the hospital, they should be in withdrawal, which is sort of a billing issue. But we can't necessarily admit people and wait for them to go into withdrawal. Whereas buprenorphine can be given in either a hospital setting or an office setting, but it does require that the patient be in moderate withdrawal. Retention in treatment is greater with methadone versus buprenorphine, and this is true also for pregnancy. However, retention in prenatal care appears to be higher with buprenorphine compared to methadone. They're both at risk for diversion, but because of the on-site administration through an OTP for methadone, it is less than what is seen with buprenorphine. The risk of OD is significantly higher with methadone as a full agonist. As we like to say in the business, methadone doesn't have a sense of humor. Buprenorphine has a little bit of a sense of humor. And while buprenorphine-related deaths solely from buprenorphine are rare, but when combined with a benzo or with alcohol, or when given in excessive amounts, say to a toddler, buprenorphine deaths are certainly recorded. For methadone, most people are stabilized to 60 to 150 milligrams. For buprenorphine, since there is a ceiling effect, most people are stabilized, and only rarely do we see people on more than 24 milligrams daily. And certainly methadone would be less convenient based on the daily dosing, and for buprenorphine would be significantly greater. Whether or not there's counseling on site will depend on the OTP, but in general is always there for methadone based on the federal regs, and may or may not in somebody's office. Psychiatry is not generally on site for methadone. There certainly are some exceptions for that. And buprenorphine can be prescribed by a psychiatrist or any other physician who is waivered. For those with multiple drugs, or for very long-standing use, or for people who really have failed really good attempts at buprenorphine, really good attempts, and prefer methadone, it is the drug of choice for them. So these are older literature about the risk of neonatal abstinence syndrome with methadone versus buprenorphine. And I'm going to present some slides which are going to also address that a little bit more carefully. But there is a decrease in the length of stay in the infants that are treated with buprenorphine versus methadone. Both are considered safe in pregnancy, and there's no difference in neurodevelopmental outcome in the limited studies that are available to date. Just other considerations is that methadone is approved during pregnancy for the treatment of women, and is associated with a lower failure rate in terms of being able to achieve sobriety and retention in care. And there are a lot of drug interactions with both these medications. This is a slide which is the biggest trial to date of opioid treatment and looks at the efficacy of Suboxone versus methadone and is not in pregnant women. And what you see, interestingly about this study, is there were 1,300 people initially randomized, but there was a significantly higher dropout rate in the buprenorphine group versus the methadone group, such that about 800 people were then followed. They were followed for 60 months, which is the longest study to date. And essentially so during the course of this study, the randomization scheme, which was originally supposed to be 1-to-1 with buprenorphine to methadone, ended up having to be changed to 2-to-1 in order to have enough people to analyze at the end of 60 months who were still on buprenorphine. But you see very similar efficacy in terms of the decrease in the number of drug-using days on a monthly basis. And while there is some decline in the no medication group, highly significant difference in the medication-assisted group. There are some alterations in the pharmacokinetics of methadone during pregnancy, which really also really speak to some of our issues. So there's a 40% increase in plasma volume by the time somebody is term, and that you start to see this as early as the first trimester. So it's not unusual for pregnant women to require an increase in their methadone dose early in pregnancy and then clearly by the third trimester. Their volume of distribution is also increased. In addition, the fraction of oral methadone that's absorbed is decreased. And then because of an increased hepatic clearance during pregnancy, the half-life just may not be the full 24 hours that we expect. Now? Can't. There we go. Can you hear me now?
Yes, we can. It's a little staticky.
Thank you. Okay.
I'm not sure why that is happening.
No.
Are you on speaker right now, Jay?
I am on speaker.
She is, yes.
Maybe you might need to try to pick up the phone if that isn't too much trouble.
Can you hear me better now?
Yes, that's way better.
Okay. And the protein I apologize for the hiccup here. The protein binding is decreased, and there is a high degree of individual variability in methadone metabolism during pregnancy. So while peak and trough testing may be helpful, actually maternal symptoms tend to predict the trough almost as closely as actually measuring the trough. So what we see during pregnancy is, since people are mostly dosed on a daily basis rather than on a twice daily basis, that because the methadone starts to run out of them early, that increasing doses are necessary. There's a higher rate of sedation earlier in the day, and they sleep through their groups, with withdrawal that recurs at 4 or 5 in the morning. So ideally, we would be dosing pregnant women on a twice daily basis. But most programs, at least in the first 90 days, are not going to allow take-home on a daily basis, and the risk of diversion certainly increases substantially. Slide's not moving.
Looks like the presentation.
Okay. Now, with respect to infant outcomes, so there have been only 4 prospective randomized controlled trials of buprenorphine versus methadone, and this is the largest. This is the mother trial, which was a double-blind, multi-center randomized controlled trial. So all women drank a drink, either a placebo or methadone, and got a sublingual tablet, either Subutex or a dummy tablet, and the investigators were also blinded to the results. So what was demonstrated was a decrease in the total dose of morphine. Yes?
I'm sorry to interrupt you. It looks like your slides are not up right now.
Okay, we are reconnecting.
I still show that you are the presenter. Right now I'm just seeing where it says the title of the webinar, and it shows Katie Horseman as the organizer.
We are re-signing in.
Okay.
Hang on, everybody. My apologies. Do I need to redial in?
I don't think that you'll need to dial in, because I mean, I can hear you. Your audio is fine.
Okay.
Okay, here, hold on.
We're not able to show the screen.
Thank you.
Okay. And so now, there we go. And so if you just want to, yep, you're back on.
Okay, thank you. My apologies, everybody. So in this mother trial, not only was there a decrease in the mean dose of morphine that was necessary in the buprenorphine group compared to methadone, there was also a decrease in the mean length of hospital stay, so 9 days versus 17 days for the methadone group. But there was also a decrease in the duration of treatment that was necessary for infants, which also transferred into a decreased length of stay. This is a meta-analysis of the randomized controlled trials or cohort studies that have been done to date. And what it demonstrated was that there was a significant decrease in the number of preterm deliveries in the buprenorphine group versus the methadone group, and this did reach the level of statistical significance. This is the largest study to date, which was retrospective and was done by Marge Meyer, who is in Vermont and has probably more experience in using buprenorphine during pregnancy than anybody else in the country. And what she demonstrated in her cohort was that there was a decrease in the, there was a decreased length of gestation in the methadone group versus the buprenorphine group, which, although statistically significant, is probably not clinically significant. But these others have both statistical and clinical significance in that there was less of a risk of preterm delivery, there was larger birth weights, bigger head circumferences, and less treatment for neonatal abstinence syndrome in the buprenorphine group versus the methadone group. But look here at the length of stay for neonatal abstinence syndrome with 83 plus or minus 60 in the buprenorphine group and 133. And these are sort of historical numbers that are not necessarily applicable today. So I think if it's all about the baby, we would always pick buprenorphine over methadone. Unfortunately, or fortunately, it is not always just about the baby, and it's really important to treat someone's pregnancy in the context of their addiction and in the context of their history and in the context of their underlying mental health condition. And there was also an increase in the number of women who were breastfeeding at the time that they were discharged from the hospital in the buprenorphine group versus methadone. So as we start to look at the treatment of addiction during pregnancy, it's essentially a third prenatal care, a third behavioral treatment. And this doesn't necessarily always translate into formalized chemical dependency treatment. This may be on-site counseling. This may be coordination of care and case management. But we really have to start looking at treating women where they are. And then a third of what we do is medication. So I asked the question, why WISH? Why have a place like ours, Women and Infant Substance Help, which essentially is a model of co-location of medication treatment for opioids, addiction treatment, and prenatal care. Well, in these 3 studies that all came out of Kaiser, in which they instituted an expert program and did brief interventions as well as having on-site specialized care for addiction, they found that the retention in prenatal care and addiction was increased after they started this program. There was a decrease in preterm deliveries when measured after onset of this program compared to before. There was a lower rate of using other substances at delivery. And then the last study, the Goler study, demonstrated this was cost effective. So let me make it very clear that when it comes to methadone or buprenorphine, there's no correlation, and this was a meta-analysis of all the trials of methadone so far. This did not involve buprenorphine. But there's no correlation between the dose of methadone or buprenorphine and the amount or the duration of neonatal withdrawal. So it is critically important that we treat the woman and make certain that she has adequate medication on board in order to prevent craving and prevent a return to drug use. Because neonatal abstinence syndrome is treatable. The consequences of return to drug use and return to a drug-seeking lifestyle and destruction of the family is not quite as easy to fix. So in terms of prenatal care, when I say counseling, sometimes this is engagement in care. We really try to meet people where they are. In our particular setting, we have a substance use counselor on site, but who also does engage in care on the phone in terms of groups and also in individual counseling. And some women are more in need than others depending on their stage of recovery. We identify and treat comorbid infectious conditions. We do not treat hepatitis C during pregnancy, but we identify HIV and make certain that care is given, as well as sexually transmitted diseases. But we do viral genotyping, viral loads, and hepatitis C education in order to prevent more transmission, and also prepare them for treatment post-delivery. We vaccinate for hepatitis A and B if their serology is negative, and then also the Tdap and influenza vaccine if the season dictates that as well. So as we address the pregnancy and ascertain fetal well-being, we monitor growth when it's indicated, particularly if women are co-using stimulant medications or non-prescribed stimulants like methamphetamine. And then we just reserve non-stress testing for when it is indicated by the maternal condition. We investigate fetal morphology in the way of a scan. When we address prenatal care, we address preterm labor prevention and education. So these are all the things that go into regular prenatal education. But cervical length screening is done routinely between 18 and 22 weeks or so. And then women who are at higher risk for preterm delivery have further attention. Consultation is done in the antepartum period by a neonatologist or a neonatal educator. We have lactation consultant on site in order to provide this intervention and also to help them navigate through what the admission will look like with respect to their infant and what to expect during the hospital, how to manage neonatal abstinence should it occur. Anesthesia consultants may be indicated. And then we identify and treat psychiatric comorbidities. And I'm going to talk about that in just a bit because of the potentials for drug interactions with psychiatric medications and also the potential implications for neonatal abstinence syndrome. There are a lot of drug interactions between buprenorphine, methadone, and many other medications, and it seems like it's a full-time job for me reining the residents in. But these are things that we should be considerate of, but should not paralyze us in our willingness to treat pregnant women. And then we do use urine drug screening, and we don't use it in a punitive sort of way at all, really just for the therapeutic benefits. So we don't maintain a chain of custody, we don't we don't call Division of Family Services as a result of a positive drug screen. And we certainly don't discharge people from care, recognizing that this is a chronic condition, but we use it more as a way to address relapses and to intervene early. So methadone induction, whether it's in an OTP or in the hospital, is we can give once somebody is admitted to the hospital with a diagnosis of withdrawal. Now, if someone is admitted to the hospital for a diagnosis other than pregnancy or other than withdrawal, you can also start methadone induction. So it's generally given as a 10 to 30 milligram single initial dose, and then with reevaluation at 4 hours or so afterwards. An additional 5 to 10 milligrams can be given if the withdrawal symptoms reappear, or if they have insufficient decrease in their withdrawal syndromes. But the ceiling dose for the first day is 40 milligrams, and this respects the pharmacology of the drug, that it takes about 5 days to reach steady state, given the same dose on a daily basis. And then after 40 milligrams is reached, we treat the symptoms. So clonidine for the anxiety, loperamide for diarrhea, ondansetron, and when they're only on 40 or 50 milligrams a day, we don't have to be quite as concerned about QT prolongation as you would in somebody on higher doses. And Benadryl orally can be used for some sedation, but we just do not give it IV. So the rules of methadone, because it doesn't have a sense of humor, is to start low and go slow, because there is a risk of overdose even when you first start it. So you can overdose somebody by going too quickly, and somebody who previously was tolerant and then went back to the same dose. And this is a classic situation that we see in overdose deaths. And there's also accumulated toxicity in people who just started too quickly and went up too rapidly. And then in combination with other other CNS depressant medications, specifically sedative, hypnotics, and alcohol. And let's also recall that benzodiazepines in the U.S. at this time are implicated in 30% of all opioid overdose deaths. So once somebody is stabilized on methadone, they are followed in an OTP. 60 to 150 milligrams is generally adequate, although they often need an increase in the third trimester. And we want to give them the least dose that's necessary to prevent them from having withdrawal symptoms and relapse. But the aim is not to detoxify. So they need to be on enough that keeps them comfortable and keeps them from using. When you're over 100 milligrams or so, trough testing may be valuable. But really, we should be giving some consideration to twice daily dosing. And for people on a stable dose and a prolonged hospitalization, sometimes we will split the dose. And then even for women in methadone, multidisciplinary care is really the key. For buprenorphine inductions, we evaluate liver functions first, although we don't hold the first dose of buprenorphine based on any waiting for the liver functions. And most people tolerate buprenorphine pretty well when they have liver functions in less than 5 times the upper limit of normal. We do engage in a consent process and a treatment agreement so that the ground rules are sort of clear, although we don't necessarily discharge them if they violate the agreement, but it may inform how often we see them, how long of prescriptions that they have, and recommendations for other intensity of treatment. We involve them in the education so that they understand the pharmacology of their medications. So in order to start, they need to be in mild to moderate withdrawal. At least a 7-12 is preferable. Some people are very frightened of having pregnant women in withdrawal, but based on the data that I showed you earlier, relatively short and not quite as intense periods of withdrawal really should not make people too anxious. There really are no guidelines regarding where you should start a buprenorphine induction. We do most of those in the office when they're pregnant, although postpartum women are certainly candidates for home inductions. But pregnant women I see in the hospital, and just sort of surveying the people who do this across the country, we're all a pretty similar thinking in this regard. And then women who are in the third trimester, usually 28 weeks or greater, I do start in the hospital, although there is monitoring that is available in my office as well. And when I think there are more studies that really speak to this directly, most likely everybody will be done in the office. So in order to achieve moderate withdrawal, we make sure that patients understand that they are abstinent from short-acting opioids for 12 to 24 hours, from long-acting opioids like oral OxyContin for at least 24 hours. And then for methadone, it generally requires a transition to either a shorter-acting narcotic so that we could start them after a briefer period of abstinence, or reduce them to 20 to 30 milligrams daily, and this requires considerable cooperation on the part of their OTP. And then they need to be abstinent for 36 set to 72 hours or so after their last dose. When we start people in the office, generally start with a 2 milligram or a 4 milligram dose given sublingually and let it completely resolve. Some people really only want to give 2 milligram doses, and it might depend on the degree of withdrawal and what their drug of choice was. And then after an observation period of a few hours, a second dose can be given if the withdrawal dissipates and then starts to reappear. If it doesn't appear that they have any evidence of precipitated withdrawal, or if they just don't have complete resolution of their withdrawal. Now, in general, we tell them that the first daily dose is 8 milligrams, but sometimes, particularly if an induction is done early in the morning, they may have 12 on the first day. And then the dosing on day 2 depends on the experience of what happens during day 1. So I know that many programs just give the buprenorphine in 8 milligram doses and then multiples of 8 milligram doses so that are on 8 or 16 or 24. And we don't do that. We use a combination of 2 milligram tabs and 8 milligram tabs to try and optimize the dose. And the average dose in WISH is between 12 and 14 milligrams. Most will and this is in the non-pregnant population, generally need 12 to 16 milligram daily, and the ceiling effect is between 10 and 16 milligrams. In pregnant women, the ceiling probably is somewhere closer to 16 milligrams or 24 milligrams in some patients. So this is a list remember that buprenorphine and methadone are cytochrome P450 3A4 substrates. So those medications that inhibit this pathway may result in increased buprenorphine or methadone levels, and those that induce them may decrease buprenorphine or methadone levels. So these are things to be considered if someone is stable and then all of a sudden experiences sedation or experiences withdrawal when you add another medication. So I listed here several medications that are routinely used during pregnancy. Paroxetine, not so much during pregnancy, more in the postpartum period, that may have implications for people on buprenorphine or methadone. We are also concerned about a lot of other drug-drug interactions, specifically when adding SSRIs and the risk of serotonin syndrome, medications that prolong the QT interval, which can occur with both buprenorphine and methadone, but much more powerfully with methadone. Those drugs that may increase the risk of sedation, and those medications that may precipitate withdrawal, specifically the narcotic agonist and the partial agonist antagonist. So with respect to many of the drugs, such as those that are used for HIV, just be cognizant that there is the potential for drug-drug interactions. And when it comes to HIV drugs, Truvada, pretty much no interactions, and whenever possible, we include that in the regimen. Dextromethorphan also can be associated with delirium when given to methadone-maintained patients. So when you consider non-stress testing, just methadone use is associated with some decrease in baseline heart rate, with variability, with a number of accelerations and fetal breathing movements. So we really only do non-stress testing when it is otherwise indicated, because we're going to create a lot of false positives as a result of just doing them routinely. There's no studies really to base these recommendations on for doing them routinely, but they're clearly indicated for people with other indications such as preeclampsia or growth restriction. If we are doing non-stress testing, we try and time it with respect to their methadone doses so that we're doing it before they dose on a daily basis or 4 hours or so later than their dose. And oftentimes, just repeating a non-stress test after a period of time will result in a reactive non-stress test that wasn't before. And then biophysical testing is done pretty much consistently, and there does not appear to be the same effect on the biophysical profile as there is on the non-stress test. Now, when somebody comes onto your labor and delivery unit for interpartum care and they're on a medication for opioid use disorder, first we ascertain that the baby is doing well and obtain urine toxicologies before we give any medications for pain for labor or other things that are indicated that may result in a false positive screen. We do rapid HIV testing if it's not already been done, and a hepatitis C testing if it's not already been done or has not been done recently. We do not use Stadol or Nubane, which are partial agonist antagonists and can precipitate withdrawal in women maintained on methadone or on buprenorphine. We do, however, provide methadone or buprenorphine during labor in order to prevent them from going into withdrawal. Cesarean deliveries are really reserved for those who have obstetric indications, and certainly while there is an increased risk in opioid dependent women, as the slide I showed you on an overall basis, not necessarily for those who are on MAT and who are well maintained. Now, there are some specific pain management issues for people on agonist medication. Because buprenorphine is a partial agonist, and because it has lower intrinsic activity, when somebody has their receptors mostly occupied by buprenorphine, lower doses of a full agonist is just not going to provide much in the way of pain relief, and you can't assume that the medication that they're on for their opioid use disorder is going to address their need for pain control either during labor or if they have a cesarean delivery. So what may be needed if an epidural is not available is other kinds of opioid medications. And then again, don't use the partial agonist antagonists. So epidurals are generally the medication of choice, and we do them earlier rather than later. Some places use a patient control epidural. And then nitrous oxide does not have any interactions with methadone or with buprenorphine, and if it's available, may augment their epidural. Usually, if used as a medication by itself, is not going to provide full relief. And then for vaginal deliveries, the epidural can be discontinued after they have their perineal repair. Sometimes if somebody has a very extensive third or fourth degree repair, you can consider continuing the epidural for a period of time. And that, of course, will have to be done at the place in your hospital where you can maintain an epidural. So for us, that's labor and delivery or an intensive care unit. So when somebody has a cesarean, what generally we recommend is a combined spinal epidural or a spinal, which should give complete relief for the surgery itself, and with an epidural can provide some relief afterwards. And in general, these are dosed with something like Duramorph that will help with pain control during the first 24 hours post-delivery. And then we reserve general anesthesia just for the usual obstetric or anesthetic considerations. Now, post-op, pain management really should can be sort of a tricky dance. We want to provide enough pain medication so that we don't increase somebody's risk of relapse from excessive pain. Likewise, we don't want to have them have excessive pain management, which may also trigger a relapse. So always the medication-assisted treatment is continued during the postpartum period, unless for one reason or another somebody ends up with an IV PCA, they choose to go off their agonist medication, in which case they'd have to have withdrawal again, and then we would restart it. So we try and optimize non-narcotic medications. So ketorolac can be very helpful. IV acetaminophen, it's available in your hospital. I can't get it. Sometimes we use gabapentin, but in general, we use scheduled dosing of pain medication to try and get ahead of the pain. So when women are seen post-cesarean, what has been demonstrated in the literature is for women on methadone, because of the increased tolerance, on average require a 70% increase in the amount of narcotic that is necessary. Now, hydromorphone and fentanyl have similar affinity for the mu receptor that buprenorphine does and are going to be more effective than those with lower affinities. But after the first 24 hours, the need for this degree of narcotic really should decrease. You may want to consider dividing the buprenorphine dose to starting with the same dose, just given more frequently. So, for example, if somebody was on 24 milligrams a day, given as 8 milligrams 3 times a day, you may want to consider giving it 6 milligrams 4 times a day. But you can do that whatever their dose is. And if they did have a general, we generally start a PCA afterwards with continuous pulse oximetry. But if that is not sufficient, and you need to go to fentanyl, they need to be moved to the ICU for that. And then transition them to oxycodone when they're tolerating PO, and with all the other guidelines that I mentioned earlier. So postpartum, we encourage breastfeeding whenever it is appropriate. And it is appropriate for women who are HIV negative, who have not demonstrated relapse within 90 days, who are engaged in care in some form. It doesn't necessarily mean that they are enrolled in treatment, although that is the recommendation of the Academy of Breastfeeding Medication. And women who should not breastfeed are people who have had a relapse within 30 days and in whom their sobriety is just not demonstrated to be durable or reliable. We avoid narcotics for vaginal deliveries, and we don't send them home with narcotics after a vaginal delivery. We have specific pain management protocols for cesareans, and at our institution, we actually keep the epidural in for 2 days so that we can make that transition to sometimes to nothing, but generally to low doses of oral medications to help them. They always room in. And so we have the expectation that the babies will be in the room with the mother because the mothers are the best treatment for neonatal abstinence syndrome. And then after we discharge the mother on the 2nd day after a vaginal delivery or a 3rd to 4th day after a cesarean delivery, we provide a courtesy room so that they can stay with the baby. And so essentially the baby is still in the hospital being monitored for withdrawal, and the mother is the overnight guest, but also the primary caretaker for the baby. And then we provide consistency of care from the antepartum period to the postpartum period, and that the MFM, who is me, sees all postpartum patients, and our social workers also follow people from the antepartum period through delivery and their postpartum stay and their discharge. So we are sort of moving away from the whole issue, the whole nomenclature of neonatal abstinence syndrome to the substance-exposed infant. And traditionally, the scoring of newborns, and that chart I showed you before, is using the Finnegan scoring system, so 31 items and a host of items to score babies on, and then decision to treat based on that scoring. So we have moved to an ESC model, which will be the next slide. But we start with non-pharmacologic treatment for those babies who do demonstrate some withdrawal. rooming in always, so the mother is readily there to assess and to comfort a baby with crying or with any issues of discomfort. Swaddling and rocking. It's a low stimulation environment with low lights and just limiting the visitors, so it's just not as much of a party atmosphere in there all the time. Infants with small and frequent feeds, frequent burping, and then skin to skin whenever possible. And then we also use high calorie formulas or supplements when the infant is being supplemented. So we've moved to the ESC model, which essentially is a Yale model for taking care of infants in the newborn. And rather than score on these 31 items, which shows a lot of intra-observer variability and sort of a low threshold to start medication, we ask, can the baby eat at least an ounce per feed? Can the baby sleep for at least an hour? And can the baby be consoled within 10 minutes? And if the baby can do those things, then medication is not necessarily indicated. And using this model results in a lower use of morphine, decreased length of stay, and no adverse outcomes. And in the EL study by Matt Grossman, they decreased their hospital costs for the newborn from $44,824 for the hospitalization down to almost as low as $10,000, with an average length of stay decreased from 22 to 5.9 days. And our average length of stay using this model is similarly 5.5 days. So breastfeeding can be critical in somebody's recovery, and it can be a significant carrot for women as a goal to be able to stay sober during their pregnancy. And so the American Academy of Pediatrics considers both methadone and buprenorphine as compatible with breastfeeding. And of interest, breastfeeding has associated with lower rates of neonatal withdrawal. So we see in this study that breastfeeding reduced the need for withdrawal medication in opioid-exposed infants who were on therapy versus those who weren't, from 53% of those not on therapy, 80% required medication for withdrawal when they were not breastfeeding versus 53% for the breastfed infants. And then those infants who were given human milk and who were breastfed at the time of delivery, after in their postpartum stay, had shorter treatment for NAS. Now, you would think that was because the babies were going to be getting a lot of medication in breast milk. And in fact, this chart shows us that there's not a lot of methadone or of buprenorphine that actually gets into breast milk. So there's a relatively low concentration in nanogram quantities for both methadone and buprenorphine. Likewise, the infant dose is similarly low, and the milk to plasma ratio in the newborn, only studied for methadone and for naltrexone, is also very similarly low. And since buprenorphine is really not bioavailable by the oral route, we really don't have that much concern. So why is there less withdrawal with breastfeeding versus non-breastfed infants? Well, it's the magic of breastfeeding. So this is just, I'm going to close out here to remind us that addiction is a chronic and it's a relapsing disease as defined. And so we have to take special care to take that into account as we care for patients. And while the relapse rates for drug addiction in that 40 to 60% range are very similar to what we see with type 1 diabetes and hypertension and asthma, and we're seriously not talking about weaning women off their hypertensive medications, their asthma medications, and their diabetes medications after they deliver. And so we have to recognize that women are still going to have these underlying issues even after they deliver. So in conclusion, opioid replacement medication is the standard of care, and discontinuing it would be indicated rarely, if ever. While methadone is the only FDA-approved medication for MAT during pregnancy. Buprenorphine is really an excellent first-line treatment. This population requires a multidisciplinary approach, and then breastfeeding should be encouraged in all women who are abstinent from opioids. And I thank you for your attention, and I'm going to be happy to entertain questions. We're looking for the questions.
Dr. Chaikin. So if you have your questions pane open, I have flagged just to kind of keep us out of going through the ones that we're talking about audio.
I'm only seeing the questions one line at a time, so it's really going to be better for you to ask me the questions.
Okay, sure. So the first question that we have is, are there any studies underway to determine if naltrexone might be safe? And this was sent at 30.
The answer to that is no. So there are some data in animals that would suggest that there is an increased risk of teratogenicity. In humans, these have not been studied. In Western Australia, there are several trials of women who have had naltrexone, and there it's available in a pellet formulation, and I didn't see any studies that even addressed the IM long-term depot formulation Vivitrol. So I can tell you that we and a couple other people are reviewing our data from women who have inadvertently gotten naltrexone while they were pregnant and are going to put them together. We're having to sort of find those based on ICD-9 codes, so it's going to be it's challenging. There may be a trial that may be starting, but as of now, we don't have data to really offer that. That being said, I have started naltrexone before in pregnant women with alcohol use disorder because, you know, weighing the risks and benefits of alcohol, a known teratogen, versus naltrexone, a medication of uncertain teratogenicity, the benefits do outweigh the risks.
Okay. On to the next question. What are the effects on the baby if the mother goes through withdrawal during pregnancy?
Well, I think I tried to address that. We know of no acute effects that result in any increase in the risk of stillbirth or of miscarriage or of distress during labor or prematurity. But because we don't recommend it because it increases somebody's risk to relapse, we don't know. Now, whether there is an intrauterine withdrawal syndrome that is important and may change the HPA programming for stress reactions later in life, we don't really know. And because there's unlikely to be randomized controlled trials addressing this, I think this is going to remain a question for quite a while.
Okay, thank you. Next question, has Dr. Chaikin done any kind of chart review to determine what ICD-10-CM codes are being used on patient records of NAS-diagnosed babies? Further, that this person that asked the question says that they're curious from a surveillance perspective.
The answer to have I? Oh, no. There is a trial underway, mostly looking at ENC in our nursery population. So there may be some information there on the neonatal end.
Okay. And then it looks like the last question, and we've had a number of these, it looks like our audience is wanting to know if they'll be able to access the slides that you've presented today.
In a PDF format, we can make those available.
Okay, sure. And what I was going to say, Dr. Scheiken, if you, I can have you send it to me in a PDF form, and then if anybody in our audience would like to have that PDF, if they want to email me that request, I'm happy to forward it on
Okay.
with the PDF file.
And if there are other questions or questions that come up, I would be happy to answer them more directly and more thoroughly by email as well.
Okay. All right. Do you prefer that they email me and then I forward it on to you, or do you want to provide your email address? Whichever is fine.
Let's do it through you, and if there's really a lot, we can have them sent to me.
Sure. Okay. That sounds great. And then it looks like we just had another question come in. Do you need informed consent in Missouri to test pregnant? I'm not sure what the rest of that.
Oh, urine drug screening? Well, screening.
Possibly.
I hope I am answering the correct question, but urine drug screening.
That is correct.
Urine drug screening is not a really terrific way to screen for substance use. If it's not done universally, it is fraught with prejudice on the front end. So we reserve urine drug screening for women who do say that they are using. We use it to monitor treatment, and we use it for specific medical indications. What is really much more effective is to do an interview in a private situation in which confidentiality is guaranteed and in a non-judgmental fashion, so that someone will open themselves to avail themselves of help if they identify themselves as using. And then the other issue with urine drug screening is that it's only going to give you a very narrow window of what has happened within a few days of her peeing into that cup. So that being said, if it is done in the context of medical treatment, it does not necessarily require consent when the baby is tested. Now, if the mother is tested, this should be done with consent. And then if someone chooses not to consent, it is documented.
Another question, are there any more webinars available related to this topic that you're aware of?
No, but we could certainly make those happen if they're requested.
Okay. All right. Well, I think it looks like those are all the questions that we have received. Did you have anything else that you'd like to say?
No, I thank everybody for their attention and for being patient during our technological hiccups.
It's very common. It happens. All right. Well, if that is all we have, I'd like to thank everybody that joined us today. I'd also like to thank you, Dr. Scheiken, for taking your time and providing such a great presentation for everyone.
Indeed, my pleasure. Thank you.
All right. Thank you, everyone. Bye-bye.